Hello, this is Dr. Sarah Wise. I'm going to spend the next 30 minutes or so talking about allergic fungal rhinosinusitis. These are my current disclosures. This lecture is being recorded on December 17th, 2024. So these disclosures are current as of that date. We're going to talk a bit today about the medical and surgical management of allergic fungal rhinosinusitis. We'll talk about the diagnostic criteria. There are some other aspects of allergic fungal rhinosinusitis, such as pathophysiology and some of the various controversies with this disease process that we will not be spending a lot of time on. We'll keep this talk more in the clinical realm of evaluation and management. So we'll begin with a case. This is a 26-year-old woman who presents with a primary complaint of nasal obstruction, mostly on the left-hand side with congestion that's consistent for at least 6 to 8 months. There's also some sneezing and rhinorrhea that is exacerbated during the spring and fall seasons. And this has been particularly worse since moving to the southeast state of Georgia about 4 years prior. Patient describes occasional mucoid discharge from the left-hand side with a gooey consistency, also complains of some hyposmia. There's no facial pain or headache. And then there's a history of kind of an allergic phenotype with childhood reactive airways, although asthma has not really been a prevalent thing over the last 15 years. The patient's brother does have asthma, however. So on the right-hand side of the screen, you can see a classic nasal endoscopy of this condition, which demonstrates polyps and thick, almost iridescent appearing mucin. And we'll look at a CT scan as well. So coronal views going anterior to posterior, we can first notice that the left frontal sinus is opacified. The sinuses on the right-hand side are less affected. There's less mucosal disease there. On the left, we can see some heterogeneous densities in the maxillary sinus. And as we go further back, we can also see heterogeneous densities within the sphenoid sinus, and then some areas of bony erosion and expansion around the sphenoid, particularly of the inner sinus septum and the skull base of the sphenoid. On surgical endoscopy, we'll take a look at that here on the left. We see some edematous, kind of watery polyps. This is the patient's left-hand side. And this thick peanut butter-like mucin that comes out of the maxillary sinus. We can take down some of the additional polyps. Those tend to breed out rather easily. And then this is in the ethmoid cavity. So just behind that, we encounter additional pockets of mucin. The pathology on the right-hand side, the top photo is an H&E stain that shows some various patches of eosinophils, and then on the bottom is a fungal stain, which is positive for fungal forms. So this is a case of allergic fungal rhinosinusitis. Patients frequently present with nasal obstruction and hyposmia. Pain is rare. Oftentimes they'll describe a gooey mucoid discharge. And then this tends to have a regional predilection in the US for areas of the Southeast, although it can be seen in other regions. And the geographic distribution of allergic fungal rhinosinusitis may be expanding related to climate change. Patients often have a history related to atopic disease and are typically positive on systemic allergy testing. So in 1994, the Bent and Kuhn criteria for allergic fungal rhinosinusitis were published. So type 1 IgE-mediated hypersensitivity, typically to not only molds or fungus, but also these patients are often sensitive to lots of different allergens and classes. Nasal polyposis on examination, the characteristic CT findings that we talked about, the heterogeneous densities in the sinuses. This is often asymmetric and can be unilateral, and there can be bone erosion or expansion seen. And then on pathology, we see eosinophilic mucin without fungal invasion and a positive fungal stain. And this is specifically stain rather than culture, because with modern fungal culture techniques, we can see almost everyone having positive results depending on the culturing method. So throughout the rest of the talk, we're going to look at some of the evidence as it relates to medical management of allergic fungal rhinosinusitis. Specifically, we'll also talk about surgical management. And most of this evidence comes from two large consensus documents published in 2021 with ICAR rhinosinusitis, as you see on the left, and then 2020 with the EPOS document. So this is a chart from the EPOS document that shows a kind of a schematic of how to break down primary chronic rhinosinusitis. And so they first break it down by localized, unilateral or diffuse bilateral, and then type 2 or non-type 2 disease. And you can see that allergic fungal rhinosinusitis actually appears in both the localized unilateral and the diffuse bilateral categories, because there can be some variability. This disease can be unilateral or bilateral. And historically, it's about 50-50. So when we look on imaging, there are some classic features that we notice on CT scan. So as I mentioned, it can be unilateral or bilateral, and you can see some examples of both of those here. But I want to highlight that very, very commonly, even if the disease is bilateral, it often has asymmetric features. So on the right-hand side, you can see some examples of bilateral disease, but it's not really symmetric from side to side. And that can be a great clue to identifying allergic fungal rhinosinusitis. Also, the heterogeneous densities. So within the sinus cavities, we see both dark and light areas. The lighter areas as where the mucin or the fungus is most concentrated. And then, as I previously mentioned, some areas of bone erosion or expansion can also be seen, although not always. All of these examples that I've provided here do show some bone erosion and expansion. On MRI, so here you can see on the left a CT scan, and on the right-hand side an MRI of the same patient. So on the MRI, some of the things that we often see are increased attenuation of the sinus mucosa, and that correlates to the areas of inflammation of the mucosa, and then decreased attenuation in areas of fungal debris. And this often looks like essentially a dropout of the MRI signal. So when we think about preoperative management, the EPOS document looked at the evidence related to systemic corticosteroids for allergic fungal rhinosinusitis. And it has been shown that preoperative corticosteroids seem to have a more dramatic effect in allergic fungal rhinosinusitis compared to standard CRS with nasal polyp patients. And if significant doses of systemic corticosteroids are given, you can potentially actually achieve near normalization of the mucosa at the time of surgery. So surgery is a mainstay of treatment for allergic fungal rhinosinusitis, and there are several goals of surgery. So in surgery, we will typically perform this endoscopically. We'll remove polyps, we'll widen the sinus ostia, and remove the mucin. So this helps to aerate the sinuses It removes the immunologic stimulus. It provides access for topical therapies. And as I mentioned previously, it can support our diagnosis. So on pathology, we can identify the eosinophilic mucin and then perform fungal stains to identify those non-invasive fungal hyphae. So when we think about removing the mucin, as you've seen, that mucin can be very thick and can be somewhat difficult to remove from the sinuses. So these are some of the things that some of the techniques that I've kind of incorporated over years and years of taking care of these patients. So we want to widely open the sinus ostia or the natural sinus drainage pathways. And oftentimes, with the burden of mucin, that sort of naturally widens the sinuses for us. We want to remove the polyps, and then we kind of suction, use curettes, irrigate. Have to be very patient because this mucin can be very tenacious. It can want to kind of stick to things. So oftentimes during the surgery, I'll sort of move around to different areas after I've opened the sinuses, work in other sinuses and let the mucin kind of relax and come away from the sinus walls. And we may have to be creative with the instruments that we use depending on where we're working and if we're trying to work around different corners of the sinuses. So we'll oftentimes use angled endoscopes, and you can see that the endoscopes come in various degrees for improved visualization of certain areas. So 0-degree scope looks straight ahead, 30, 45, and 70-degree scopes look at those angles, and then the post of the scope can be either a regular or reverse post, which can move the post out of the way of the instruments. And then you can see some examples of various instrumentation over on the right-hand side with different curvatures and different things that we can use to help us get the mucin out. So we want to widely open the sinus ostia. So this is an example endoscopic photo that I showed before. During surgery, we want to really open things up and kind of clear that mucin out. And then as the mucosa heals, we want to have wide open sinus ostia so we can get the rinses in. And so, as I mentioned, that mucin can be tenacious. There can be lots of polyps at the sinus ostia. So this is not the type of condition that we want to treat by just poking a hole in the sinus and placing a suction there. We really want to open those sinus ostia widely. Oftentimes, just in primary sinus surgery for allergic fungal rhinosinusitis, just performing a standard endoscopic sinus surgery with wide ostia can be sufficient, but some people have advocated more aggressive approaches or extended sinus ostia. So this is an example publication that looked at endoscopic modified medial maxillectomy or megaantrostomy. So that's basically in the maxillary sinus, taking that medial wall down to the nasal floor to provide sort of the maximum degree of opening of that sinus to the nasal cavity and to allow gravity-dependent clearance of the mucin and improved visualization and the ability to debride in the clinic. When we think about the frontal sinus, there have been some publications relating to extended surgery of the frontal sinus. PJ Wormold's group in Adelaide, Australia, has published very frequently on this. This is an example publication looking at the use of an endoscopic modified Lothrop or draft 3 frontal sinusotomy, which is basically connecting the bilateral frontal sinuses and creating the maximum opening into the nasal cavity. So essentially from medial orbit to medial orbit. They did note in their analysis of endoscopic modified Lothrop procedures that there were a few characteristics that increased the risk of failure of this surgery. One was nasal polyps, another was asthma, another was a high Len chi-score, and another was a small frontal ostium size. And they said that if there are multiple risk factors for failure, you might consider performing this extended frontal opening as a primary procedure. And as I've shown, nasal polyps and significant opacification of the sinuses or high Lynn-Mackay scores are frequent in allergic fungal rhinosinusitis patients. So this same group actually looked at their outcomes with endoscopic modified low throat procedure and found that in a mean follow-up of 45 months, they had a 95% success rate. However, allergic fungal rhinosinusitis was a significant risk factor for revision of an endoscopic modified low throat. Oftentimes, this was just a soft tissue revision, so removing additional polyps and mucin without significantly additional bony work. So when we look at a postoperative result in an allergic fungal rhinosinusitis patient, this is an example here. This is the patient's left side. This is looking at a maxillary sinus. This is about 6 weeks post-op. And then looking up at the frontal sinus, and you can see some pulsations posteriorly. That's actually an area of skull base erosion that the patient had. The soft tissue was intact, so the sinus mucosa, the dura, so reconstructing that bony defect is not necessary. That will likely eventually reform the bone over time and does not need reconstruction. So thinking about postoperative management of allergic fungal rhinosinusitis, there are various different options. The mainstay of our long-term postoperative management is topical steroids, and this in today's treatment paradigm is typically performed with high-volume steroid irrigations. Some people still use oral steroids for short-term postoperatively, as well as for intermittent exacerbations. The table I'm showing here reviews some of the evidence. This is about 10 years old now, but this was a pretty comprehensive review at the time of various types of medical management strategies for allergic fungal sinusitis following endoscopic sinus surgery. And you can see that the best evidence is for oral steroids. I would highlight that this is not keeping the patients on oral steroids permanently, but rather using them in the short term. And then there are some various other medical therapies, and we'll go through some of these. So oral corticosteroids, the ICAR document looked at oral corticosteroids for CRS with nasal polyps overall. This was not specific to allergic fungal rhinosinusitis, but keeping in mind that AFRS is a type of chronic rhinosinusitis with nasal polyps, there's a strong recommendation for the use of oral corticosteroids for the short-term management of CRS with nasal polyps. The EPOS document specifically looked at postoperative systemic steroids for allergic fungal rhinosinusitis and found fairly high levels of evidence to say that this improves short-term outcomes in AFRS and are likely to reduce long-term recurrences. And you can see some of the evidence here. I think we're all aware that systemic steroids have pretty extensive risks, and many of those are listed here, although this is not an absolutely exhaustive list. But these potential risks should not be minimized and should be certainly kept in mind if there are repeated courses of systemic corticosteroids. As I mentioned previously, one of our surgical goals is to provide access for topical therapies, and topical high-volume steroid rinses are really one of the mainstays of long-term management for CRS with nasal polyps, as well as allergic fungal rhinosinusitis. This is an off-label use of these steroid rinses, but is fairly standard in rhinologic treatment. And we can see here why this is the case. When we perform endoscopic sinus surgery, we're providing significantly more access for these topical therapies. So in the chart on the left-hand side, you can see the difference between pre-op and post-op with the ability of these steroid rinses to reach the sinuses. This was a cadaver study that we did when I was associated with my fellowship at Medical University of South Carolina. And you can see the various sinuses labeled on the bottom of this chart on the left-hand side, with particularly increased penetration of the frontal and sphenoid sinuses postoperatively. We can also see that the degree of surgery affects steroid penetration as well. So the graph on the right-hand side goes from no surgery to standard endoscopic sinus surgery to medial maxillectomy. And you can see that there are significant differences in the ability of those rinses to reach within the sinuses. So topical corticosteroids, as I mentioned, standard postoperative therapy. So the ICAR rhinosinusitis document looked at intranasal corticosteroids, standard delivery, in other words, nasal steroid spray, and provided a strong recommendation for the use of topical intranasal corticosteroids in spray form for CRS with nasal polyps. Non-standard delivery has been a bit less studied, but the evidence for various topical delivery methods were examined in this document. So irrigation, exhalation delivery device, nebulization, et cetera. And you can see that there's various degrees of recommendation. In the most right-hand column, you can see a strong recommendation for corticosteroid irrigation, option for exhalation delivery, and a recommendation for nebulization, all based on level A evidence. The EPOS document also looked at non-standard versus intranasal corticosteroids specifically for allergic fungal rhinosinusitis, and found that non-standard nebulization of intranasal corticosteroids is better than simple sprays, but intranasal corticosteroids of any type are useful in controlling allergic fungal rhinosinusitis. What about antifungals? The evidence is less strong here. So primarily based on the fact that this is an inflammatory disease rather than a fungal infection, we typically aim our treatments at controlling the inflammation rather than eradicating the fungus. However, in recalcitrant cases, sometimes antifungals are employed. The evidence here is shown in the left from the ICAR document. Antifungals can be considered an option, topical or oral, in AFRS patients that are recalcitrant to maximal topical steroid therapy and immunotherapy. And then the EPOS document comments that oral antifungals may reduce inflammation and recurrence in allergic fungal rhinosinusitis. Oral antifungals may reduce recurrence in AFRS, although a meta-analysis was negative. They do not improve symptoms, and topical antifungals may be beneficial. So a bit lower levels of evidence noted for antifungals as seen here. What about allergy and immunotherapy? So as we noted, the Benton-Kuhn criteria have type 1 hypersensitivity as one of the criteria for allergic fungal rhinosinusitis. So how prevalent is allergy in AFRS? We looked at this in a cohort of our patients, subcategorized into various CRS with nasal polyp subtypes, and you can see that graph on the right-hand side. 100% of allergic fungal rhinosinusitis patients were allergic. And you can see the differences between the various groups there on the right-hand side. So immunotherapy, allergen immunotherapy in allergic fungal rhinosinusitis is something that is often talked about, but really rigorous studies on this have been very limited. So as you can see here, this is the 2014 publication, but it basically shows that many of the studies are fairly low levels of evidence with very, very few subjects. Many of these were primarily observational. The largest study, at least published at this time, was level 3B evidence with 60 patients. So the ICAR and EPOS recommendations for immunotherapy, ICAR first basically has determined that this is an option with an aggregate grade of evidence that was not really able to be graded. And so says that immunotherapy may be an option for AFRS patients if they have other allergic symptoms. And then the EPOS document says, based on level 2B evidence, that immunotherapy to both fungal and non-fungal antigens in atopic individuals with AFRS is likely to improve symptoms and reduce revision surgery. There are a couple things that we'll do when we treat exacerbations of allergic fungal rhinosinusitis. So previously mentioned, short courses of oral steroids can be helpful. We can potentially adjust the topical steroid regimen, increasing the dose. We can debride these patients in the clinic, and oftentimes in my experience, I'll treat them with oral or topical steroids and bring them back with short interval follow-up to progressively debride that mucin out and hopefully avoid a return trip to the operating room. And then some practitioners will use oral antifungals or topical antifungals for recalcitrant patients. We do have to consider monitoring liver function tests in the oral antifungals. So finally, a few words about biologics. This is obviously something that certainly excites rhinologists, otolaryngologists, allergists, and immunologists. And so we can see here many of the biologic targets that we're familiar with, including the IL-4 alpha receptor, various aspects of eosinophils, and then IgE. So there have not yet been any published biologics trials for allergic fungal rhinosinusitis, but there certainly has been some experience with the treatment of AFRS patients who were on biologics because they had comorbid asthma, et cetera. Many of the large biologics trials for CRS with nasal polyps excluded AFRS patients. But we do know that a subset of AFRS patients have asthma and have been on biologics, and there are some published case reports or case series in the literature. So here we can see from the ICAR rhinosinusitis document some of the experience with omalizumab, early experience with omalizumab in AFRS patients. And the aggregate grade of evidence was a level B, ultimately policy level of option with consideration to use in difficult to treat AFRS patients. There's also a case series published with the use of dupilumab, and you can see here some fairly significant improvement as evidenced by the change in CT scan on the right-hand side. You can see the SNOT-22s with significant improvement in 4 cases. Also the asthma measures, ACT score, FEV1, and then FEV1 to FVC ratio. At the 2022 ARS annual meeting, there was a presentation on dupilumab in use in 13 patients who met the Benton-Kuhn criteria for AFRS, and 10 out of 13 showed a median reduction of nasal polyp score of 2 points. And 9 out of 10 improved more than 9 points in their SNOT-22 scores. And I think many of us are familiar with the Liberty trial for allergic fungal rhinosinusitis investigating dupilumab. This is just a quick case example of dupilumab, a patient who is enrolled in the dupilumab trial. So you can see the baseline endoscopy and then 2 weeks after starting the study drug. At this point, it was not known whether the patient was on active treatment with dupilumab or placebo. So I guess I will leave that to you all to guess for yourself. We started a study at Emory. Unfortunately, the study has been closed by the sponsor due to funding issues, but we started to look at add-on dupilumab for allergic fungal rhinosinusitis used as post-operative therapy to prevent recurrence of AFRS, given its tendency towards recalcitrance and recurrence. And I'm sad to say that this trial has been closed, and so we will not have the results of this, but we were very excited about it when we started to enroll. And final thoughts, I think, we have this is something that many of us who practice in the Southeast US and some other areas see very frequently. It's a big part of my practice. Allergic fungal rhinosinusitis is something that I enjoy taking care of, and I enjoy seeing people improve with surgery and appropriate therapy. I think we need more studies on the effect of allergen immunotherapy in AFRS. And also, I think we're all excited about the potential role of biologics in the treatment of AFRS. And we'll have more to come on that in the future. So thank you so much.